Hello everyone and welcome to today's lecture. Today we will speak about pneumonia in children. So first of all, pneumonia is a common respiratory infection that will cause an inflammation in the alveoli and the lung tissue. It can get caused by viruses, bacteria and fungi, and it's a major cause of morbidity and mortality in children worldwide. So, the etiology of pneumonia can be viral, as we mentioned. So, the most common in children are the respiratory syncytial virus, influenza, adenovirus, and parainfluenza. The bacterial causes can be Streptococcus pneumoniae, the most common, Haemophilus influenza, Staphylococcus aureus, and Mycoplasma pneumoniae. The fungal causes are rare, but they are possible and can be Candida or Aspergillus. The aspiration pneumonia is when we will have inhalation of food, liquids, or foreign bodies, and it's common in some children with some neurodevelopmental problems. Aspiration pneumonia, it will happen due to the inhalation of food, liquids, or foreign objects, and it's common in the children with neurodevelopmental disorders. The pathogenesis. So first of all, we have the pathogen. They will enter the lower respiratory tract either by inhalation, aspiration, or hematogenous separate. Then it will trigger inflammatory response that will lead to alveolar filling with fluid, pus, and inflammatory cells, and this will impair. We know that the alveolar is the oxygen exchange place, so this will impair this function. Then we will have bronchoconstriction and increased mucus production that will lead to airway obstruction. So for the examination plan, first of all, we will have inspection and we will see the kid looking ill and he will have some fever. Then we will check his respiratory rate because tachycardia is a key finding. Then we will look out for any respiratory distress symptoms like nasal flaring, subcostal or intracostal retractions, and cyanosis. Here we are revising the normal resting respiratory rates in children. So for the newborns, the breaths are from 30 to 60, 1 to 6 months are 30 to 50, 6 to 12 months are 24 to 46, 1 to 4 years is 20 to 30, 4 to 6 is 20 to 25, 6 to 12 is 6 to 20, and above 12 is 12 to 16. For the examination plan, we will do an auscultation. So first of all, we will hear fine crackles that will suggest that there is an alveolar involvement. Then we will also, it's possible to hear bronchial breath sounds, which lead to consolidation. This breath sound is usually heard in the second intercostal space. And we will have maybe decreased breath sounds that will indicate large consolidation or effusion. Because we know consolidation is the condition when we will have accumulation of fluid or pus in the alveoli. Wheezing is possible in atypical pneumonia. Atypical pneumonia is a kind of pneumonia that doesn't follow the typical symptoms of pneumonia or viral pneumonia. Percussion in any place with consolidation fluid, we will have dullness or hyperresonance if we have a pneumothorax. This is not a very common thing in pneumonia, but it's also possible. Hyperresonance is when we do percussion, we will hear like a higher sound than normal because there's only air, there's no lung. Now we will hear the crackles to make sure that we know it. So this was fine crackles. Now let's go back, and I think I added another type of crackles just to differentiate. Yes, this is coarse crackles, so let's hear it. It is like deeper. It's in a chronic bronchitis. It's also pneumonia as well. Now we hear the bronchial breath sound.
In this video, we're going to review bronchial breath. And they're a hollow sound, and they're going to be bronchial breath sounds.
So just to not get confused, the most sound that you'll hear is crackles, fine crackles, the first one. So for the laboratory instrumental studies, with the blood test, we will have leukocytosis with neutrophilia if we had a bacterial infection, leukopenia inside of if we have viral or severe bacterial. The CRP and ESR will be high, very high, if we had a bacterial infection, and maybe normal or slightly elevated if we had a viral infection. Procalcitonin will have higher than 0.5 if we have a bacterial, and less if we have viral, and the normal is less than 0.1. A blood culture of sepsis is suspected. For the imaging, chest X-ray is a really important diagnostic tool in pneumonia. So if we had a lobar consolidation, we will have a bacterial pneumonia. If we have a bilateral interstitial infiltration, we will have a viral pneumonia. And if we have a pleural effusion, it's a complicated pneumonia. We will do an ultrasound if we suspected a pleural effusion, and CT if we, and severe cases. So first of all, this is the lobar consultation. We know that we have 3 loops in the right lung and 2 in the left lung. So here we have the upper loop consultation. Here we have pneumonia in just one loop. We are seeing that there the opacity of the lung is different than the other loops of the lung. So we have here consultation. In this picture, as we see here, is bordered, so we have consultation here. In this case, I won't say, just try to guess it yourself. Obviously, I'm sure you will get it correct. Here in the lower loop, we have it. In this X-ray, we have it in both loops, in both lungs. To be honest, it's bilateral interstitial infiltrate, so it suggests a viral pneumonia. Here as well, this is a 1 and this is a 1, so bilateral. Here we can see pleural effusion. As a note, everything black is air, white is a fluid, so all this is a fluid. This is the lung, and we know we see that the lung is collapsed and all this is filled with fluid. Here also we have pleural effusion. One of the things that are important, the pleural effusion, this one is really clear, but in case in the lung that have a pleural effusion, we won't see the costophrenic angle. So look, the costophrenic angle is disappeared, so we have a pleural effusion here. As well here and here, do you see the look, this the what you called the costophrenic angle, how nice is this, how nice it is here. Look here, it's disappeared. It's disappeared. So we have pleural effusion, as well as the diaphragm levels are not the same. So pneumonia can be hospital acquired. It will occur 48 hours or more after hospital admission. The common pathogens are Pseudomonas aeruginosa, MRSA, and Klebsiella achnylobacter. It's more severe and usually is antibiotic resistant. So for the treatment, we'll talk about 2 things in the treatment. First of all, this beautiful, easy chart. So if we have a viral infection, any viral infection, we'll start with a supportive care, and then we can do a symptomatic treatment like antibiotics for the fever. If we have a bacterial community acquired, we will use amoxicillin or ceftriaxone. for mild cases, amoxicillin. If we have a typical pneumonia, we'll go with azithromycin, macrolides. And if we have aspiration pneumonia, we'll go ampicillin, sulbactam, or clindamycin. For the hospital acquired, which is the severe kind of pneumonia, we'll go with vancomycin, piperacillin, and tazobactam. I also brought you a very beautiful. You can find the link in the description if you want to read it all. It's like a small book. I forget what you call a small book in English. So it's from the World Health Organization. So they have some criteria for the treatment for the pneumonia. So let's read it. So with children with fast breathing pneumonia, with no chest syndrome, there's no changes in the inspection of the chest. They are breathing fast, tachypnea. General danger signs should be treated with oral amoxicillin, at least 40 milligrams per kg per dose twice daily, or 80 milligrams per kg a day. So this is the first thing. The second thing, children aged between 2 or 59 months with chest syndrome, this time we have chest syndrome pneumonia, should be treated with oral amoxicillin and the same dosage for 5 days. Children aged between 2 and 59 months with severe pneumonia should be treated with parental ampicillin and gentamicin as a first line of treatment. If this didn't work, we will go to ceftriaxone. For ampicillin plus gentamicin or ceftriaxone are recommended as a first line of treatment antibiotic regime for HIV-infected and exposed infants, and for children under 5 years of age with chest syndrome pneumonia or severe pneumonia. And you can read the whole like the small book in the description and get to know, because every recommendation have like an explanation why did they recommend this. That's actually everything for today. Thank you so much for watching. I hope you found this lecture useful. Thank you. Goodbye.